pleasure to introduce my senior colleague, Associate Professor David Dossetor, who is Clinical Associate Professor in Psychiatry at the Children's Hospital Westmead and Director for Mental Health Sydney Children's Hospitals Network. David is a child psychiatrist with a special interest in intellectual disability and autism spectrum disorder. David is also team leader of the Developmental Psychiatry team at the Children's Hospital at Westmead, and through various partnerships he's led research and service development in mental health promotion, prevention and intervention for children and young people with intellectual disability and also autism spectrum disorder. And today David is going to talk about clinical expertise in responding to the mental health needs of children and young people.
Thank you for inviting me to speak today, and I first want to acknowledge my partners in developmental psychiatry, my team colleagues, some of whom are here today, particularly from the schooling colleagues, but particularly my interagency partners in disability and education. And I can attest that with collaboration with these agencies, we can have a world standard of practice in New South Wales. But to paint the context, when you think that between 1 in 20 or 1 in 50 families that have a child with an intellectual disability has been said, 40% have severe emotional behavioural problems. And this emotional behavioural problems has more effect on the family than the disability itself. In UK, they demonstrated that this constitutes 14% of the burden of care of all psychiatric disorder. And in fact, if you include autism, CAMS activity, child mental health activity in UK goes up to 25%. It is now a human rights issue that people with intellectual disability should expect equitable access, which means 3 or 4 times the access of neurotypicals. And there's growing evidence that the quality of services really do affect mortality, social inclusion, such as employment and sustaining family care. Brief history. I was training in UK in child psychiatry and intellectual disability, and it was decreed children should no longer be brought up in hospital, and I witnessed the reform of moving these vulnerable children from hospital wards to homes. Here in 1987, funding for people with intellectual disability was transferred from health to a social model where it's remained. The problems of the emotional behavioural disturbance led to the development of the Training Resource Unit, which was a behavioural approach to all emotional behavioural disturbance. But it really led the seeds to a diagnostic overshadowing, because one agency would think of emotional behavioural disturbance purely in behavioural terms, and mental health had a cop-out. But over time, there have been these growth of specialised manuals to aid the diagnosis in this population. And life is improving for these people. And yet, when you look at, for example, the study called Left Behind, we've all been improving. And in fact, as we've become more affluent, people with intellectual disability have been left behind the progress that other people have made. And now, of course, we're faced with the NDIS. The Canberra Round Table on Mental Health and Intellectual Disability had strong consumer voices which said they need greater access to mental health and greater expertise in this area. So, what are the differences of psychiatric disorder in this group? Well, they have much greater more common anxiety disorders, including trauma-related, attention deficit disorder, oppositional defiant disorder, autistic spectrum disorder. They have, surprisingly, less substance abuse. With issues like depression, eating disorder, psychosis, and personality disorder, it gets contentious because of the difficulty of reliable identification of the diagnosis. And these disorders vary with the IQ. But there's also a range of different complex disorders. And when we talk about the Child Global Assessment Scale in the 30s, that's really severe impairment, with things like extreme repetitive self-injurious behaviour, extraordinary levels of anxiety, hyperactivity, in sightless rage and violence, often driven by stereotypic preoccupation. And the families. I frequently come across parents with murder-suicide ideation as the only solution, which really is a measure of how little attention we pay to these families as a community. And indeed, with these severe problems, you really do need interagency collaboration. If you look at kids with autistic spectrum disorder, as mentioned before, research shows that up to 80% of school-age kids have a psychiatric disorder, and 40% have more than one. So there clearly is an increased risk of a psychiatric disorder with intellectual disability. And there's similar sorts of range of increased problems of various anxiety disorders, disruptive behaviour disorders, but tics, Tourette's, encopresis, enuresis, motor coordination, language problems, depression, bipolar, psychosis, and even the sensory processing disorders. In fact, clinic populations show that 95% had 3 or more conditions, and 75% had 5 or more, which fits in with my experience. In New South Wales, reports show that 70% of people with autism are bullied, have no friends, don't fit in. 70% needed access to services. They felt that mental health services excluded people on the basis of intellectual disability or autism. Parents stated that educators were not well informed, and it was estimated 100,000 people in Australia with ASD have mental health problems, and that they fall between the cracks of disability services. But there is good evidence that treatment works in this group. We know that parent training is the most effective intervention for mental health for all children, and this applies equally for kids with intellectual disability. And we've been involved in implementing stepping stones training in special schools with dramatic benefits. There is now a New South Wales, or there's a MySay project where this is being rolled out across the eastern seaboard as an intervention study looking at changing the epidemiology of disturbance and its cost effectiveness. Behaviour therapy has Cochrane levels of evidence, although there's some reservation about long-term effects. Cognitive behaviour therapy is effective in control studies, but sometimes need modification with a greater emphasis on teaching skills as well as standard processes. Pharmacology is, again, there are problems with pharmacology because the problems are so severe that you often need the pharmacology. On the other hand, you have increased rates of side effects. But it's quite clear it's a critical role for the more severe conditions. And then our group talk a lot about developmental psychiatric disorders that need skill-building approaches, which is really in keeping with the adult model of recovery. And it needs a range of skills with speech, emotional social development, family therapy and systems understanding, building independent skills, motor coordination, sensory play therapy, dialectical behaviour therapy, modified trauma-based therapy and special education. Now, we were fortunate to be funded by both Mental Health and ADAC to develop a training curriculum project, which I still contend is the first of its kind in the world. It was led by Donna White, who's here at the back. That certainly demonstrated to us that there was a huge anxiety about these problems, a huge need. And the framework focused on the child in the context of a family. It was necessary to have a common language to assess and treat emotional behavioural disturbance, which was a bio-developmental psychosocial cultural model. And the skill-building process requiring many subspecialty skills. Jim talked about the importance of doctors and the health problems, but physiotherapists, the occupational therapists, the speech therapists, the psychologists, the psychiatrists, and the family therapists and the role of risk management. Now this combination illustrates that no one agency can do it on its own. So it was a framework that was applicable to all professionals working with children with intellectual disability in the context of a child in the family life cycle, with a focus on the quality of life and the developmental framework. It also looks at the need to consider different models of understanding behaviour disturbance. And we need to have service structures which are problem solving in their shape. And importantly, we need to look at prevention, promotion, early intervention, which really has been a neglected area. Now, when you're looking at the clinical adjustments for interviewing, there are a number of practical adjustments to make in any interview. First of all, there's always the risk of discrimination, but I found demonstrating acceptance of people with intellectual disability is the best way to set the standard. A belief that anyone with a disability or a mental health problem and their family can have a quality of life enables a starting point for respect and positive valorisation. Preferably before or at least early in the interview, establish with the parent or carer what the patient would need to cope with the clinical interview. Some may need special arrangements for leaving the room with an additional carer. Sometimes you need to take the interview to a place like the garden where the patient feels comfortable. Some may need special arrangements. Early on, you need to establish their communication capacity. It's always good to engage with them early to make them feel welcome, but sometimes it's easier to wait till they've settled and engage at their pace. So you'll often need to validate observations or things said with parents, carers and the school. You need to allow adequate time for the communication of the child, family and other professionals. The child and family assessment, where previously they don't feel listened to or are acutely stressed, takes time. I allow 2 hours for initial assessment. Many of these guideline comments are common to all child mental health. A full assessment of the developmental profile is central to understanding both the behaviour, their conceptualisation, and in turn their mental state. Capacity theory of mind and social reciprocity are central. Developmental profile also helps to understand the capacity for decision making. It's only through interdisciplinary, interagency collaboration one can appreciate the range of skills that can contribute. And the more complex the case, the more this will apply. Mental health problems for people with intellectual disability has this additional focus on developmental disorders, and treatment often involves enabling development skills and in the mind. What's happened? There we go. I just want to briefly mention our schooling project run by Jodie and Heber, who are here at the back of the class, because this has been a very exciting project, building awareness and advocacy, particularly with our journal, a copy of which is available at the back of the room. It's free, and it's such a growing area, such an exciting area to work in. We have a huge amount of educational output. We are particularly focused on the prevention, promotion, early intervention. I mentioned the stepping stones. We've developed an intervention for autism, which I suspect will be the cheapest available intervention for school-age people, called emotion-based social skills training. And Jessica has been a recent success of a mental health awareness raising project where we trained 1,200 teachers and other staff in mental health awareness and what you can do about it in schools. I hope we can show you Jessica during the course of the day. Finally, services need to focus on families and carers. When you look at the reasons why families break down with a child with intellectual disability, there are 4 reasons established. First of all, there's the difficulties of adjusting to a special or different child. Secondly, there's the difficulty of managing the main handicap, which is the burden of care. Third is the problem of looking after the carer's well-being and the family relationships. And fourth, the difficulties of understanding and managing psychiatric disorder. And so any service structure has to tackle all four of these. In fact, the families that break down tend to have problems in all these areas, although there is a developmental sequence to this too. So I think that parent training is what helps you attune to your child. Providing support and respite is a key ingredient to these families surviving. We need to look after the carers, and they need to be attuned to the well-being of other members of their family and understanding family systems and service systems. And then lastly, we need to look at dealing with these complex problems and enabling skill building. When we did an audit of our cases, it's important to realise that the impairment from the mental health problem is just as great as the impairment from the intellectual disability. And yet, our findings is that's the impairment that is reversible, and it becomes an essential service provision that we focus on improving their disability from the mental health problems. Thank you.